Okay, we're going to get started. Welcome, everyone, and thanks for joining us tonight. I'm Lisa Hunter Romanelli, the CEO of the REACH Institute. REACH is a national nonprofit, and our mission is to ensure that the most effective, scientifically proven mental health care reaches all children and families. We're here tonight to talk about how to support kids who have lost a parent due to COVID. Recent statistics indicate that approximately 40,000 children in the US have lost a parent due to COVID-19, and that tragedy has disproportionately affected Black children. So it's really important for those who care for and care about children to learn how to support kids who have lost a parent due to COVID, so that they can really thrive despite that tragedy. Because we know that children who have lost a parent are at greater risk for a host of adverse consequences. So tonight, with the help of our panelists, who I'll introduce in a moment, we're going to have a conversation on how to support these kids. Before introducing the panelists, I'd like to thank our partners who helped us put this webinar together. And those partners are Rady Children's Hospital, Vista Hill Foundation, Smart Care Behavioral Health Consultation Services, and the I just want to make sure I get the correct name of our last sponsor. Bear with me for a second. Our final sponsor is Children's Primary Care Medical Group. So thank you to all of our sponsors for helping us bring this webinar to you today. So now on to an introduction of our panelists. We're lucky to have with us three great panelists who have a lot of information about this topic that they're eager to share with you. Our first panelist is Alyssa Label. She is a program manager at Smart Care Behavioral Health Consultation Services and the Vista Hill Foundation. We also have here with us today Bill Saltzman, who's a clinical psychologist and the director of the Marriage and Family Therapy Program at California State University, Long Beach, and Christopher Lane, who is the Program Director of Education in Evidence-Based Practice at the UCLA Duke University National Center for Child Traumatic Stress. So in a minute, each of our panelists will be providing some introductory remarks. And after those remarks, we will open up this for question and answers from the audience. During the remarks, please feel free to put into the chat box any questions that you may have, and we'll be monitoring those questions so that during the question and answer period, you'll get answers to the questions. So with that, let me pass it over to Alyssa for her introductory remarks.
Thank you so much, Lisa. It's an honor to be here today. I was thrilled to learn what our subject matter was, because this is something that my program has been working with firsthand for this last year. And first, to give you some context as to how we're coming in contact with families and communities, I'd like to let you know what our program does. Smart Care Behavioral Health Consultation Services is a program of Vista Hill Foundation, and we were created, we're a county-funded program that was created to support primary care doctors with mental health and behavioral health issues. So if a mental health or behavioral health issue pops up into a primary care office, they get referred to us, and we go from there. We do warm handoffs, we connect with long-term services, we assess what's going on, and some more support primary care in handling behavioral health and mental health issues in their office. So what we've been seeing over this last year is that there has been a significant increase in parent and care death that has happened in our community in San Diego. What I would like to do is to give you a couple of case examples of things that we're seeing, of stories that we're seeing. I unfortunately was trying to make a list of the different stories, and sadly I had over 24 that I could choose from. So it just shows that normally we would have 10 parent deaths, and we had over double that in this last year due to COVID. So the first case I would like to bring up is a case of a mother with 4 children. And she was referred to us after her primary care doctor found out that her husband had COVID, was in the ER, and was living in the ICU for 6 weeks before he passed away. At the time that she met with her pediatrician, her husband had been dead for over a month, but she had not been able to tell her children. So her 4 children had no idea that their father had passed, and mother was really just completely overwhelmed. Didn't know how to have that conversation, didn't know how she was going to really cope with the day as it was given to her. Her first and primary concern, I mean, the pediatrician really wanted us to help her out and get her into some counseling, but we really quickly realized that this mother was so overwhelmed because she had become the primary breadwinner of her home and she was struggling. She didn't know how she was going to make ends meet, and she had 4 small children, all under the age of 6, that she had to figure out how to get childcare for. She also was, she and all of her children are Black, and this was at the end of August, and this is right after the George Floyd murder had happened. And so her children knew that their father had COVID-19, but she was also fielding questions from her children if their father had been murdered, or just a lot of questions that were really hard for her to have that conversation. So first thing we did was contact her and figure out what can we do to make your life a little easier. And what we had to do is get her financial services. Right now she was stuck with not being able to pay her rent, not knowing how her children were going to survive. So what we did is we connected them with the Social Security Administration, because a lot of people, and I would say pretty much 9 times out of 10 of a parental or caregiver death that we learn about, the family does not know that children and spouses are eligible for Social Security benefits. They're eligible up to 50 to 75%, depending on the case, and a family benefit of 150 to 180%. So that's the very first thing that we get started. At that point, you figure out what is the hierarchy of needs. If we don't fix the hierarchy of needs and get some relief into the family, we'll never be able to reach them with counseling alone. So this is something that we have to do so that they can reap the benefits of counseling. And that's when we got them connected with counseling at that point. There's many, many other cases that I could go over. We have, in San Diego, we do have a lot of undocumented individuals. We have a young girl who her father had passed away, and we didn't know that her father had passed away. The pediatrician didn't know, but the pediatrician, actually at Children's Primary Care Medical Group, they do a wonderful job of screening their children, and the child tested positive for a significant score on the PHQ-9 for depression. And so we were able to talk, and by being able to talk with one of our consultants, we were able to find out that the child's father had passed away, but the mother was too scared to mention it, access any services, because she was worried that if somebody found out, she would be deported. So this was a real life or death situation, or huge stakes that need to be addressed here that most people wouldn't think that that's something that you would have to deal with. But in these disadvantaged communities that we're working with, there's so many other factors that are playing into what's going on for the families. It's not just, I lost my parent, it's I lost my parent and. So I know that I sort of taking up too much of my time. I have many, many more stories that I could go through, but really a big component is figuring out what other resources are needed and understanding that it may be a different experience for depending on what community you're in.
Thank you, Alyssa. That was really interesting to hear those stories, and it, as you said, it kind of highlights that for these children and families, that the death is something in addition to other stressors that they're having. So it's not only addressing the death, but also supporting them with dealing with their other stressors. So thank you for those stories. I'm going to move things to Bill Saltzman. Bill, do you want to share your introductory comments?
Sure. Thank you, Alyssa, for getting our feet on the ground with those specific case stories. I'm also, my working with families contending with a loss and a traumatic loss. It's from my work with chronically ill and cancer patients at Cedars-Sinai and UCLA Medical Center. And then in terms of the pandemic work, as I direct the MFT program, Cal State Long Beach. So we've got 40 practicum sites. And so I'm really supervising and seeing the numbers of families that are coming to us. So let me make a few comments here. Just the general comment that, losing a parent is a life-changing event whenever it happens. But of course, it's a much bigger event for young children, school-age children, and even teens. So in these ages, especially for the younger, when the parent is a much larger part of their world, and and the parents are a critical pillar of the child's sense of safety and belonging. So there's a lot of research that we're not going to go over about risk and protective factors for kids and families contending with these kind of losses. But for instance, some of the strongest predictors of the negative outcomes following the death of a family member have to do with the circumstances of the death. So it's, as Alyssa was saying, it's like the death but what are the circumstances of it? And here with COVID, we've got a unique traumagenic kind of mix of different circumstances that include, in many cases, the suddenness and the rapid, decline of the loved one, the fact that you're losing a parent in a premature way, especially in terms of the normal family developmental cycle, the fact that the illness is often accompanied by visible suffering and distress that the kids can see. Further, as also Alyssa was alluding to, the death can take place in the hospital or ICU in which the loved ones cannot even have contact or maybe even adequately say goodbye. And perhaps even until recently, families were barred from having the immediate and tactile support of families and friends and the type of shared grieving rituals that we've counted on that help to contain and give shape to the grief. So these circumstances are largely outside of the family's control. But the part that I'm going to focus on, however, is that the research also shows us that the strongest predictors of perhaps a positive outcome for kids and family from a death of this kind, it involves the quality of support provided after the death, especially within the family. And these things are potentially very much within the family's control. So my part of the panel is to talk about some of the things that my team has learned over the last 25 years, and Chris Lane is part of this team, and Julie Caplow and others. We've responded to a lot of urgent crisis, large-scale events in which there's large-scale forms of death. And want to talk about some of the practical things we've learned. The idea that we focus a lot on helping the caregiver or the parent or the surviving parent or caregiver to take care of themselves so that they are available to provide a safe and open place for children to bring their feelings. Could be their fears, their confusion, their anger, whatever is coming up for them. You want to help the surviving parent or caregiver to be accessible, responsive, and engaged, and to create a consistent and caring holding environment at home in which both parent and child can weather the storm together and possibly even become stronger as a result. There's two general patterns that we've noticed, this simplifies it, things that can happen in a family following, a death. One is when there can be maybe the parent that models response in many ways goes into like an emotional lockdown, or there's this kind of unsafe zone for sharing, individual reactions. A lot of times this is from being feeling that they've got to be strong for the kids to protect the children, which might involve hiding or suppressing their own emotions and maybe making them less able to tolerate the reactions of the kids. It varies by developmental age and by individual. And that intolerance can be related, of course, to their own pain and reactivity. The result is kind of a distancing of the family, you see kind of a siloed grieving response in which a lot of the family members feel alone, and there's these very limited opportunities to reach out to each other and grieve together. So in place of that kind of a cycle or that kind of cascade of events, we think it can be helpful to work with the surviving parent or caregivers to develop a positive supporting cycle of interactions in which the parent helps to normalize grief reactions, to model appropriate sharing of their own pain, are able to listen to the kids, validate and respond in helpful ways, importantly, maintain regular care routines and appropriate boundaries, and develop shared ways to reminisce and honor their lost loved ones together. So what I'm proposing, and we'll get into some of the nuts and bolts of this. This is not high level stuff involving a lot of training for you or for the parent or the caregivers. Much of what I'm going to be talking about, it builds on what they're already doing. I think it's important to highlight the strengths and the good things that the parents and the family members are already doing and to build upon that, and as well as to access their cultural and religious resources. So that's what I hope to do in the rest of the talk and respond to any questions you have on practical ways to help families migrate to that kind of a response. I'm done.
Sorry, thank you. Thanks, Bill, for those comments. And I love that you highlighted the importance of the surviving caretaker or caregiver to getting support for him or herself to be able to support their kids. It's kind of like making sure you take the oxygen before you give it to the kid when you're on a plane. So thank you for those comments. And I'm sure you'll have a lot more to share with folks about practical tips that they can use to support kids in the Q&A section. So I'm going to move things to Chris, who will make his comments, and then we'll get into our Q&A.
Okay, happy to do that. And thank you both, Alyssa and Bill, for, I think, a very solid grounding of this in sort of how it appears sometimes in clinics or in clinical practice. I think setting the stage for the very human part of what we're facing right now, which is literally a national, very public health emergency, essentially. And that is just, we have many deaths that are occurring under traumatic or tragic circumstances. And I recognize I'm coming in with sort of more of a scientist practitioner hat on, because that's what I do for a living. But I just like to emphasize, for those of you particularly who, for whom making a diagnosis is an integral part of what you do, whether it's in risk screening or clinical diagnosis, et cetera, a new diagnosis called prolonged grief disorder is going to be coming out in DSM-5-TR, which is slated to come out this summer. So literally any moment that the American Psychiatric Association posts this to their website, it is an official disorder. And that is a new development, and I think a very important evolution in the field itself. So I want to talk a little bit about that. There are specific diagnostic criteria, and I plan to share that. Those are also going to go out in slides we're going to make available at the end of this presentation here. But I also want to acknowledge, I've been working with bereavement and grief now for about 25 years. Beginning with my doctoral dissertation, et cetera. Grief is the most difficult thing to be able to assess of all the different types of problems I work with, PTSD and anxiety, depression, et cetera, because it changes so much across cultures and across different developmental ages and so forth, but also different circumstances of the death and different relationships to the deceased. And so that presents a particular type of problem for us to be able to make sure that we'll be able to get a correct reading on how a person is grieving, and to be able to demarcate distinctions between whether they're grieving in adaptive ways and grieving in ways that actually merit clinical concern. And it's what I call the Charlie Brown problem. And that is that we have good grief, and that is the elephant in the room whenever you're working with a bereaved person, because grief itself is a normal and adaptive process. It is not specific to humans. We have grieving whales and geese and dogs and horses. It's found throughout the animal kingdom. It is a highly natural process, but it nevertheless can, in some cases, go awry. And the best available evidence is that between 10 and 15% of bereaved individuals actually reach a level of difficulty where it merits clinical concern, where it actually might merit a diagnosis, as well as in-depth assessment and grief-focused intervention. I should mention that elements of COVID, as well as our other deaths of despair, and that is things like suicide and drug overdoses, for example, or dying due to alcohol abuse, et cetera. These are epidemics that are also spiking, opioid overdose, et cetera. So we've got a number of different epidemics that are either driven by COVID or I think honestly by the economic restrictions and the social restrictions that have attended COVID. And so all of these are concerns for us. Just to give you some idea about the magnitude of the problem, the last time we actually had a full 3-year plateau in the national life expectancy, which is a general gauge of overall population health, was back in 1918, where World War I and the Spanish flu epidemic sort of combined to kill over 500,000 Americans. This is the first time in 60 years when we've actually had in excess of a 1-year decrease in the national life expectancy. The last time this happened was 1943, and that was while World War II was raging. So we're literally now at essentially a 60-year high in terms of a drop of the national life expectancy. And this is very sobering for us. Something that's also of concern is there are certain groups, as we know, that are at differentially elevated risk, the elderly. And so we might say that kids in particular and families are at risk for losing their grandparents, except for the fact that many families are non-traditional and grandparents or the older individuals are actually assuming primary caregiving roles. And so this is very important. And for those of you who are working in clinic settings, pediatric settings, et cetera, we recommend actually routine screening for bereavement because frankly, it is touching so many families in so many different ways that people may be adversely impacted. And as we've noted, there is a statistical elevation in likelihood for many different difficulties associated with bereavement. Lots of likelihoods go up for PTSD and psychotic disorders, depression, et cetera. But statistical risk is not certainty. The fact is that the great majority of people who are bereaved still grieve within the adaptive range, et cetera. And so we actually want to have a more hopeful way of looking at this. Nevertheless, bereavement itself presents a particular challenge for it because it is not only the most frequently endorsed major stressful life event, it is routinely ranked as the most stressful life event that people undergo over their entire lives. So we have something that is very, very frequent in its occurrence and very, very stressful. So whether people have, if you will, a clinically significant outcome or not, it is a huge life-changing event and something that merits our care and concern. And so I think just as an overview, that's a good point, and we can transition to more in-depth comments later.
Great, thank you, Chris. So we're going to move into the question and answer section of our presentation today. And so I invite everyone, if you have any questions, to please put them into the chat. We also got some questions in advance of the webinar, so I'm going to pose some of those questions to our panelists now, and then as other questions come in, we will address those questions as well. So our first question is for Bill, and if you could share with us some specific skills and practices that a parent or caregiver can draw upon to help his or her kids and the family after the death of a parent. I think that would be really helpful for everyone to just get a sense of some specific things that parents could do to help kids who lost a parent. Oops. You're on mute, Bill.
Now I am. Here I am. Okay. Yeah, the centerpiece of this has to do with the parents or caregivers, their ability to be present and to be able to listen to the kids. It's, especially in circumstances like Alyssa was describing, there's so much pulling these folks in every different way. It's hard to be present and to hold space and to, to carve out attention to check in with the kids. But it is the most important thing that they can do. And you kind of give them permission to prioritize this, and also the idea that in order for them to do that well, they've got to take care of themselves. And so they've got to, if they are, of course, they're going through their pain and they're being pulled by finance and maybe dislocation, all kinds of things that are pulling at them. But for them to be able to hold a space, even for short periods of time, or maybe to access the caregiver who is most able to do that, to be able to create opportunities to listen to the child, to be curious, to reflect, validate with no lecturing or advice, you know. Part of this also is how the parent kind of sets the tone for how the family is going to respond. So the idea about modeling openness and kind of expectation that these, of course, these are hard times and we might all have different reactions, but we can do this, you know, we want to, that you want to hear from them. So you can support the parents to do that by being in part transparent themselves, to share some piece of their pathway, you know, and to talk about the expected ups and downs that they're going to go through. It's going to be maybe like a roller coaster. Other pieces to kind of how to work with parents and to establish appropriate boundaries. A lot of times kids can see the parent in tremendous distress and they might be taking on too much stuff for themselves, or maybe they're going to be protective themselves and not talk about what's hurtful, or when they're having bad times at school or when they're alone by themselves. So, you know, there's an exercise we do called What is My Job and What is Not My Job, and to work with the kids to do that. The idea of, and then very briefly, the idea that staying in touch with the children and having this kind of open conversation, it's not a single thing, it's many small moments. And it's good for the parents to build in regular, even scheduled opportunities to do this. One-on-one opportunities, even family times, things like this. I'm thinking of Alyssa's case in which the parents had trouble to even have the conversation to tell that the parent had died, you know. And my working in cancer support community in Cedars-Sinai, this is not uncommon. How would you even broach this topic of maybe whether the parent is in the process of dying or has died? And so this is to build that kind of safe place where the parent often needs support as well to have those hard conversations, and you can be part of that as well. The final thing is just to identify trauma, identify the loss reminders and difficult days. So you get a kind of sense of when will be expected times when they might have, their hearts might be really hurting. You know, maybe it's anniversaries or holidays or specific reminders that are specific to that family. Sitting down for dinner, times when they did special things with the lost loved one, you know, and to be sensitive to those unique triggers that will really evoke that kind of difficult, painful response, and to stay and maintain contact. I'm going to cut it short there.
No, that's fine. Thanks, Bill. And so it sounds like the parents and caregivers have to balance that open communication, so, you know, allowing kids to share their feelings, but also be careful that the parent is also keeping boundaries if the child is not overwhelmed by the parent's own experience. So it's this delicate balance of both things. And so that's related to another question, and this is for Alyssa. You know, how can families build resilience in the face of, you know, having lost a loved one? Sounds like you have a lot of experience working with families who are facing this, and what are some strategies to help them build resilience?
Absolutely, absolutely. And I mean, Bill gave a great start of how you start to build resilience. You open the space for people to have these conversations. Another thing and a big resource is you look for their community. Find their communities, their community, their family. Do they have a large family? Or is it their neighbors, the people around them? Is it their church? Is it their religious support, you know, their religious group? Find supports for the family that are outside of the family to help. And that's been one of the biggest challenges actually over the last year with COVID-19, and why we're seeing kids have much more severe symptoms after the death of a parent, is because they don't have that sense of community that they may have had access to before. they have been more socially isolated. So anywhere you can bring in family, we work with families to be like, okay, how to do family FaceTime, how to do family Zoom calls, how to reach out and be able to tell people you're having a hard time, you need some help and support. Another thing is to really encourage doing family engaging activities. It's still important to maybe do a movie night. It's still really important to do all the things that make you feel better, within reason. Your kids will feel better too. So to really just focus on family bonding time, doing things together, reaching out for help in your community, and reaching out for professional help too. That there's wonderful grief counselors out there all over the nation. We have a wonderful group in San Diego, and in every city I've worked in, there's been a wonderful hospice care group where you can go and you can get grief counseling.
Great, those are great ideas, and I think your idea about just kind of keeping some of the family rituals in place even after the death sounds like that's really key. So we have another question, and this is for Chris. What are some of the specific risks and complications due to COVID-19 related deaths that those might carry for developing the prolonged grief disorder and related complications that you had mentioned?
Great, thank you. And I'm enjoying the comments from my fellow panelists right here, because I think what they're really helping us to do is think like clinicians and to see things through a clinical lens. One of the issues when we're approaching COVID-related deaths is that technically you can code this as death due to natural causes. This is a disease. It's not the same thing as a homicide, for example, or a traffic fatality. And one of the things, I want to pick up a strand that Bill was talking about earlier, and that is, if we're talking about what we call sort of traumatogenic elements, and that is things that actually can evoke a lot of distress, even perhaps traumatic stress reactions to the circumstances of the death. Two things I want to make clear right here. The first one is that even deaths due to natural causes can contain a multitude of traumatic elements to them. So for example, he alluded to the fact that, kids coming in, for instance, and watching a loved one who's dying, especially if you're young and you're seeing people breathing through tubes and so forth, and they're in a lot of pain, or it's a wasting illness and they can't care for themselves. They may have changed color, etc. All these sorts of things for a child can actually be potentially traumatogenic. We published a study a couple of years ago that actually showed that kids whose loved ones died due to a wasting illness actually had higher PTSD scores than kids who died suddenly, for example, of a heart attack or a stroke. So it's important for us to recognize that there could be many different elements related to the circumstances of the death that can be found in a COVID-related death as well. And Bill was also alluding to the fact that a lot of the leave taking and caretaking rituals that we have for literally loving a person while they're alive and loving their body and their memory while they're dead, many of these actually have been sort of truncated and interfered with. There are lots of barriers that make it difficult for people to be able to do that. So in general, the evidence indicates that the likelihood of actually developing prolonged grief disorder reactions increases under conditions, yes, of traumatic deaths, but also under very tragic deaths. And it's important to recognize that distress over the circumstances of the death can be expanded, not just about sort of, the shock or the horror of how they died, but a lot of rumination, for example, about just, I feel responsible for how they died. I wish that I would have done more. I wasn't there when they died. I didn't get to say goodbye. I didn't get to make peace with them. I feel bad about ways in which I treated them while they're still alive. These are things that actually come up and are prominent in the data we have from children and adolescents. So it's really important to sort of think much more broadly about what circumstance-related distress looks like. And then in the aftermath, it's also very important to be looking for factors such as a lot of uncertainty and existential challenges, for instance, a lot of economic insecurity and strain, living with a caregiver who him or herself may actually be under a lot of distress, etc. One thing I wanted to add is that we've seen kids who will literally shut off their grief because they're so concerned about overwhelming their caregiver that when we actually have grief sort of sharing activities, the caregiver is sometimes really surprised about the depth of the child's pain, of the adolescent's pain. They said, I know you missed your father. I had no idea about the current depth of your pain. And so you can actually have elements where kids don't share that with their caregiver. And I think also, if you're trying to look for where to draw the line, if a caregiver says, well, I can talk about my grief because that's going to help my child, give my child space and permission to talk about their own grief reactions. If you sort of say, is there a place where we can draw the line? If it seems that a child is shutting off his or her grief reactions out of a concern of overwhelming the caregiver and wanting to protect them, that may be an instance actually where more professional care is warranted to facilitate those sorts of good communications. And I would also say it's important to create a space for caregivers who truly feel overwhelmed with their grief, but don't want to weep in front of their children, to come in and actually get help for that pain in ways that are more private and away from their children, if we actually think it's not that helpful for the children to witness that level of anguish. Two final thoughts. It's important to recognize trauma reminders. Those are reminders of how the person died, and it can be hospitals, it can be ambulances, it can be medical personnel, it can be shows, the sound of gunshots, whatever it is. Or loss reminders, which are very common in the aftermath of even peaceful deaths. So the person's name, belongings, etc. They're quite different creatures. The loss reminders are potent evokers of grief reactions. Trauma reminders actually can evoke not only grief reactions, but actually post-traumatic stress reactions and depressive reactions, etc. So it's important to recognize that, especially for people who are bereaved under traumatic or tragic circumstances, they may be dealing with reminders of how the person died and reminders that the person died. And both of those can be challenging for the child, and that can be part of that intervention work.
Thank you. That's really helpful way of helping folks distinguish what's at play, particularly with these COVID related deaths. I want to encourage folks, if you have questions, to please put them in the chat box. But we do have others that came in, and this question was somebody from one of our audience members, and Bill, I thought you might be able to offer some suggestions, and other panelists might have thoughts too. The question is, my 5-year-old nephew lost his mom a couple weeks ago. He has since had a decrease in appetite, but is claiming it is due to a loose tooth. Is it typical for kids not to acknowledge grief symptoms? How do you address grief when the child is unwilling or unable to acknowledge it?
Yeah, that's a great and a fairly an important question as well. Yeah, it is not uncommon for for kids to come up with some kind of maybe instead of like showing sadness, or I'm sad, or I really miss mommy, whatever, is to have a physical complaint or some kind of a pain that is more tangible like that. Um, and it's always good to go with what they bring to you. That's where you start. You go, oh, this it hurts. Tell me how and how long, and to be caring and to hear them and to validate how painful this is. And you always reflect what's there. And go with that. But you also find opportunities to try to expand that conversation. And you can, even from the pain of the tooth, maybe that's a metaphor for maybe other members in the family, we also are feeling pain too. We're feeling pain in our hearts, and maybe I don't feel so good physically, but you can kind of bridge. For a 5-year-old, you want to keep it very straightforward, and you can talk about the different types of pain, perhaps, and even share the pain that you're experiencing as the parent or caregiver. And partly what you're wanting to do is to make it safe for the child to start, even the 4 or 5-year-olds who, like Chris is saying, they can be protective of you, of the parent. And they're going to put on hold or abort their own grief or sadness because they don't want to make it worse or add more, or maybe they're embarrassed or ashamed of this, And they get messages from school or different people that they should, maybe it's a couple of months past and they're still feeling pain and loss in those empty situations, like the loss reminders Chris was talking about, times when their heart sinks when they sit down at the table and, mom's not there, or, the person who used to, cook dinner, she isn't there. So you want to provide that safe place to expand that conversation, often by you, the parent, modeling it's okay. We can talk about this. We can talk about this as a family, and we're not going to come apart. And there's not going to be any shame or terrible repercussion, because I feel it too. And, and so you make it okay in that way. I keep talking on and on, but is that enough?
No, I think that was a great answer to the question, and really the idea of kind of using the child's language and sort of meeting them where they're at to talk about what they're bringing to you. Alyssa, in your introductory comments, you mentioned the case of the family who was reluctant to share that there had been a loss. So I was wondering what advice you could give our audience for how to screen for grief and loss, with families who may not be disclosing or are afraid to disclose.
Absolutely. And I'm really glad you asked. I think in order to answer that question, you have to look at why they might not be disclosing. We're talking about some communities that are disadvantaged and have they're either experienced institutional racism throughout their life, and they may not be very trustful of who they're coming to talk to. They might not be trustful of their doctor or therapy. This might be one of their first experiences with therapy. It could also be an issue, like I said before, where there's an actual consequence that you could be ripped away from your child in a deportation concern. There's also, we have in San Diego, we're beautiful and wonderful and it looks like a vacation spot, but we are also housing some of the largest homeless population that is happening in America right now. And it's because it's livable conditions if you have to live outside. There's a reason why Los Angeles and California have a higher homeless population. And because of that, you have a lot of people who've been put in shelters. And that is the most, they were the most at risk of anyone who could be exposed to COVID-19. You also have to look at why their loved one might have gotten COVID-19. And that could be because these people are essential workers. They're the ones that are out there. They're filling your grocery bags. They're doing all the work in the food service that we're still requiring people, but we still need for society to go on. And they're the ones that are taking the brunt of the exposure. So it's understandable that they would have a hesitancy to coming in and disclosing. Using screening tools for not necessarily, if you can do it for bereavement, wonderful. Using a screening tool just like the GAD, screening for anxiety, screening for depression, screening for ACEs. It'll pop up sometimes on your ACEs. And like Christopher was saying, this is the ACE of all ACEs that pop up. So by doing that, and this is actually how we got a lot of our cases, because they didn't disclose to their primary care doctor, but it showed up on a screening tool. And so we can take over and then we can have that conversation of, is there anything else going on? Anything that caused stress in your family? Anything that's created an additional hardship? And also open up that, you don't report to anyone. We're lucky because we're a free service where we're like, we don't report to anyone. We're here to help you and get you whatever service you need and make it real clear that their information is safe with us.
Thank you. Those are some great suggestions, and the screening tools are invaluable. So a few questions that have come in from our audience. The first one is how best to address the possibility that a child may have felt that they spread the disease, that the remaining parent is susceptible to the disease. And that question is coming in from Lynn. I don't know who wants to take that on the panel.
I think that one of the things we can just say is just simply that if we remember the famous dictum of Carl Rogers, the 1960s feel-good person-centered therapist, the facts are friendly. And in this case, evidence actually is helpful. And the evidence indicates that the children have very, very low risk of transmission. That's just simply the evidence right there, that the children, it just doesn't happen. And the second is just simply to emphasize that people are taking good care of one another, and especially if they're following sort of basic recommended health routines, et cetera, then I think it just helps to recognize that everybody is doing their best, that that children are actually very safe to be around, and that, that we're going to get through this in general. But that is sort of that circumstance-related distress that we've been talking about right here. And especially with younger kids who sometimes don't have a real clear understanding of causality, for example, or statistical probability, it's very easy for kids to overappraise the likelihood that they've done something wrong. In the same sense, for example, that I got mad at dad and dad got cancer or got in a car accident. So sometimes some very basic cognitive behavioral techniques of just helping kids to understand, that they don't have control over a lot of these types of things can be soothing for kids.
Thank you. We have another question from Carrie about, and Alyssa, you alluded to this a little bit in terms of like different, and I think Bill did too, cultural and religious approaches to talking about grief. So the question is, can you address dealing with different religious, cultural approaches to sharing or acknowledging grief? So I guess, how as a therapist or primary care provider, anybody who's supporting a family who's dealing with grief, how can you take into account their cultural and religious beliefs to make sure you're doing that in a sensitive, culturally sensitive way? Alyssa, you want to start?
Jump in on that one?
Yeah.
Okay. Great question. Thank you, whoever asked it, because it's important to do your homework. It's important to learn about other cultures and to know about other cultural practices, especially ones that might be very different than your own. So do as much homework as you can, and then take all of that with a grain of salt, because you cannot generalize every person in every culture. So be informed, but also be open to hear what their specific cultural practices are. I had a professor once that told me that there are infinite cultures, just because there's cultures that are growing and developing everywhere you go. So do know what's going on, but also take direction from your client. Ask questions like, are there any rituals, or is there anything you've done to honor your loved one? Ask questions that are asking about, what their practices are, rather than saying like, have you done something for your, or, have you done a ceremony based on your culture? Just being real gentle and understanding and open, and doing your best to support them and encourage them. If there's something that they want to be doing that they don't feel comfortable doing, that as long as it's safe for everyone, really encourage them to do it, and that you support them in their culture.
Great. So that sounds like you're recommending asking and finding out as a way of helping to support others if you don't know what their own cultural.
And never assume.
Yeah, never assume. And this question, I think Chris partially answered, but just to make sure, I will ask it. The question is, what if the elder member of a family passed away because of COVID, and the kids are positive but mild or totally asymptomatic, and the kids feel guilty, I guess, about maybe causing the death of the elder member of the family? So how to support those kids who might feel that?
Yeah, that's kind of like, I'll just jump in quickly. That's like a horror story, or that's, actually, I was afraid of that in my own family. I'm at risk, and my son was still out in the world, and I go, wouldn't that be horrific if he got me sick? God, that would be the worst possibility. So here, and you got a situation, and it might have happened. It's unclear, and although Chris makes a good point, it's unlikely, but it still is possible. The first thing is go back to this thing about you can't just come on to them with advice or facts like, this is unlikely. The first thing is to go where they are. They're coming to you, or maybe you even a sense, that they're worried about that. Maybe they're being quiet or withdrawn, and they somehow their behavior has changed. Well, you want to check in with that and gently explore, and you don't assume, you kind of, and try to open that up. And then as they start to share, maybe they have that thought, you don't try to squash that right away. No, that can't be it. You want to listen. And it's, it's like, to hear about their thoughts and feelings and their fears that they are, and by listening, and then, ideally, if you can help them to organize their what's going on for them. I think parents do this quite naturally, in which you're just kind of, identifying the house, they feel so bad about this and they're worried, they're scared that might have happened. So what you're doing is you're validating them. You're not saying, no, you're foolish for having those thoughts. You go, well, of course. And because you love your grandfather, that's why this is so scary for you, because, it's so important to you. And the thought of doing this really tears you up. So you're validating them, normalizing, makes sense you'd ask that. And then you can share, once you've done that, then you can share some of the information that Chris is talking about as well. And maybe you don't have a clear answer to this, but you also highlight what their heart and what their intention is. And the fact that they're so worried and that they, about their love for their grandparent.
And I concur with that. But what I would also say, and towards the back end where you may be doing some gentle challenging and so forth, is just simply to say, one of the reasons why they're letting kids go back in school is because, frankly, they're so safe. And so there are millions of kids like you who are going back to their families because it is so safe. And but I would agree with Bill, that initial sort of joining and validation work is very, very important. Let me say something that's, I'm going to piggyback a little bit also onto what Alyssa was talking about right here, and that has to do with the functions of religion. And these are quite independent of whether they're true or not. We have to think about what they do. And one could make the argument that major functions of religion actually have to deal with dealing with fears of death and death and its aftermath. And so a lot of it is honestly just a telling about where our loved ones are and the notion of a delayed reunification and how to deal with our separation distress, that is our desire to be with them, and gives us a sense of purpose and meaning about what we should be doing with our lives pursuant to that reunification. That's for people who believe in an afterlife and so forth. But what's important to keep in mind here is that a lot of our mourning rituals are culturally embedded or they're religiously embedded. And it's important to not just simply recognize that these take place and to honor that, but to think more generally about what the functions are. What functions are they serving that are actually beneficial? And to think about how your work can feed into that and facilitate that. Is it something, for example, where there's something about the mourning ritual, for instance, where they're collecting memories and mementos and so forth. And I always say, a memorial service is like, honestly, a quilting bee of bereavement, where everybody's bringing in their pieces, their stories, their narratives, and they're stitching it together into a broader narrative. And everybody leaves feeling enriched because they've learned more about the life of the person and their impact for good in so many different lives, et cetera. That, we could say that's a memorial service, it's a funeral service, et cetera, and has a religious overlay to it. But let's also recognize the beneficial function that these play and to not lose sight of ways in which we can even leverage that therapeutically. It can simply be validating it, but also talking about what they learned, for example, during a memorial service, integrating that into our grief work, for example, and thinking about ways in which people can feel close to the loved one based on things that they've learned through these sort of religious or culturally appointed rituals.
Thank you. Yeah, that is one of the, like you were saying, the tragedies of COVID is that preventing people to experience those rituals after a death and the effect that has. So we are approaching the end of our time, which has gone by very quickly. I have one more question, and then we'll see if there's any last questions from the audience. I had mentioned in the beginning that the statistics show that Black children have disproportionately lost a parent to COVID, and I was wondering. Are there any specific approaches to support Black children who have lost a parent and who generally might have less access to mental health services? So from your experience, Alyssa and Anna and Bill and Chris, do you recommend anything in particular to make sure that Black kids who have lost a parent to COVID get the support that they may need?
I'm really glad that you mentioned that. And there's a research study that came out about a month ago that showed that while Black children may only make 14% of American children, they are about 20% of the children who lost a parent or a caregiver due to COVID. I think that, really keeping an eye out for children, doing the screening that's very important. I think that oftentimes, Black children particularly don't want to make waves. And so they don't necessarily always ask for help. So that's when you need to, put on your clinical lens and kind of look around and see, like, are you noticing something, how to approach, and also normalize their experiences, normalize what getting mental health, access to mental health would be, and just reach out. You might have to talk to not just them, not just their caregiver, but sometimes different members of their family to explain that, accessing grief counseling is okay, it's normal, and it can be very helpful for all involved. And the more you get the community together, the more success you'll have.
Thanks. Bill or Chris, any thoughts about that?
What I'm going to do is I think in my prior presentation as well, I recommended reading a paper. You can download it off the internet. It's called Black Deaths Matter. It's by a sociologist by the name of Deborah Umberson. It lays out a very sobering set of studies. And she's a sociologist. She studies bereavement on a national level. What she actually found is that when you take into account just simply the sheer magnitude of losses that occur within Black communities, it's not just how they died, it's how many people died and the age at which they died, et cetera. The health disparities gap between Blacks and white Americans virtually disappeared just by factoring in disproportionate rates of bereavement. And COVID has done nothing but exacerbate these differences. So we've actually lost, I think, about 15, based on an article I read, about 15 years of progress in narrowing that race-related health disparities gap. And so it's really, it's a compounding tragedy that's very frustrating for those of us who work on this problem. So I think the very first thing is simply to recognize just the sheer prevalence of losses, and to recognize that it doesn't take a traumatic death, and it's actually a misnomer to call this traumatic grief. It should be called prolonged grief, and it doesn't take traumatic deaths. It just oftentimes the sheer number of deaths and the ensuing hardships and deprivations that can have a cumulative effect. And that oftentimes means that we're now focusing on a family or broader community, religious community, et cetera. Think much more broadly about where the resources are. I'll say one final thing. How can we harness what happens in funerals and memorial services to help people clinically? One thing I would say is, how many people came up to you and said, if there's anything that I can do to help, please let me know, and I really mean it. Take a list of those people and actually work that into your social support recruitment skills training. So in other words, now I can start thinking of literally people I can go to for different types of needs that I have, and I can think about different types of support that I can ask for. It might be instrumental. They take me to a game. It could be something else. They can help me to study, but I also might need to have a shoulder to cry on, or just somebody to take me to a movie. But we can start thinking about how to interdigitate these sort of cultural and religiously evolved ways of exchanging support, and building that into an intervention or into a therapeutic clinical intervention in ways that I think can be synergistic. And I would recommend that we think about how to do that more practically.
Thank you. And somebody just asked about the paper that you recommended, and we'll make sure to, we have everybody's email address, so we'll make sure to share that resource with the group. I'll give any last chance for any question before we close. Is there any last minute question from anybody in our audience? Well, thank you to the panelists, to our partners, and for everybody in the audience for joining us tonight. I hope that this has been informative and helpful. As I mentioned in the beginning, we will be sharing resources to everybody who attended today. Our panelists all shared some helpful resources that we will share with you. And I also want to let everyone know that we're going to be having another webinar on Monday, the 24th, which we will put in the chat, the link to register for. And that webinar is going to be on LGBTQ issues, how to support kids who identify as LGBTQ. So that might be of interest to some of you. So again, thank you everyone, and have a good night or evening, depending where you are.
Thank you, everybody. Thank you, Alyssa and Bill. Thank you for hosting us, Lisa. And Lisa.
Thank you.
Yes, thank you.
Bye, guys. Bye, everybody.
Thank you. And for attendees that are still here, there are resources in the chat that you can download. You will also get them on email.
Great.
Bye-bye.
And Lisa's, I think I sent you the Umberson paper or the link to that, but if not, I'll send it to you right now, okay?
Okay, perfect.
I have
Great.
it, Kristen.
Oh, you have it? Great.
Yep, I got it.
All right.
All right.
I dropped it in the, yeah, and I dropped it in the chat earlier. So
Great.
they're all avenues to get it.
No, it's a great article. We're all happy
Yeah.
to share.
And the new flyer will go in here, correct?
Yep.
Gotcha.
That's the last thing I just put
Oh, you
in.
just put it in there. Okay, perfect.
Okay. Well,
All right, thanks
I
everyone.
think we
Bye.
closed it off. Thank you, everybody.
That
Right,
was
have-
amazing. Thank you, guys. That was really, really good.
Good.
Guys.
Well, it's a very opportune time to be doing this. So thank you for keeping your ear to the rail on these really important social issues. Take care,
Thank you.
everybody.
All right,
Thank you.
thanks. Bye-bye.
All right. Bye, guys.